We can't have our moderator introduce himself, so I have the privilege of introducing Neil. Again, like many of the speakers, a lot of us in this room know Neil well. He's an associate professor of surgery and critical care at London. He holds a whole host of administrative titles, including the trauma director. Neil did most of his training in London, Ontario, and then spent a couple of great years in Atlanta at Grady Memorial, like so many of us in this room have or do. Neil's a really good family guy. He's a really good friend. He's a thought leader in Canada, very much like Dr. Rizzoli. And we're absolutely thrilled to have him talk to us basically about where to go with sick patients. So thank you, Neil.
Okay, thank you. So I was tasked with the job of deciding where do these patients go. We've talked a little bit about this already throughout the conference on really should we go to the CT scanner with unstable patients, should we bypass and go to the OR, should we stay around the emergency department for long? Probably not. And then we'll get into about the hybrid OR. No disclosures, and this is what we're all talking about again. It's hemorrhage control, and hemorrhage control. Here we've got I think it's a fairly reasonable matching of our ratios right here, but unfortunately there's a lot of that blood that's still spilt on the floor. So this is what we're trying to control. And this is a nice quote that I liked from Andy and from Chad, and it makes our job sound so cool. Here we are, trauma surgeons must symbolically reenact Ulysses' legendary fateful decision-making navigating between Scylla and Charybdis every day when deciding where to transport an unstable dying patient when the choices are the geographically separate OR and IR facilities. So it sounds awesome, but we do face this every day. Where are we going to go with this patient? Where are we going to go? We know that hemorrhage certainly is the most preventable cause of death in our trauma patients that we think we can have some effect on, that certainly we can save lives. We have to identify these patients. Yes, they're bleeding. We've got to diagnose where they're bleeding, and then we've got to try to treat it. All the while we're going to be resuscitating these patients and resuscitating them with blood, hopefully whole blood, or at least the components to make it that way. We know that this is true. We know this is true in Canada. Here's a paper from Sandro's group when he was working in Sunnybrook and really looked at where are the preventable deaths from hemorrhage. There's one at Sunnybrook, and really it was the pelvis and the abdomen were the two big ones. And really in this paper, at that time, it wasn't as en vogue or fashionable for pre-peritoneal packing. IR was the way to go with these unstable pelvic fractures, and even there they're advocating we need to get more interventional radiology and operating rooms together. So that's the lead into our hybrid ORs. Well, what about in South America? This is a paper from Brazil looking at the cause of death intraoperatively over a 14-year survey from a Brazilian tertiary teaching hospital. And again here, when we look through this, it's hemorrhage, head injury, hemorrhage, or all these areas that are potentially preventable. So same in Canada, same in Brazil. I'll extrapolate that to South America, to other South American countries as well, perhaps. Here's a nice paper that's about 20 years old now, looking at 8 level 1 trauma centers in the U.S. and looking at what are the causes of death in the operating room. And they wanted to look at, what are the causes there for sure, but then where are the areas and the opportunities for improvement? And again, not surprisingly, bleeding was the #1 cause. Areas for improvement they identified was a delay to get to the operating room. We've talked about time all the time, this whole conference, and that's what we'll be doing again throughout this talk. So not just delay within the institution, but interfacility transports as well, which is something that's very real that we see certainly in the Canadian environment. So time to actual control of hemorrhage is essential. We've talked a bit about this. Dr. Ordonez has talked about the platinum 10 minutes, and I really like that. This golden hour is perhaps a bit more historical. But delays to the operative intervention in patients with significant abdominal injuries have a 1% higher mortality risk every 3 minutes you delay them to get to the operating room. When you think about it, that's a staggering number. But it's just some more evidence to say that you've got to get hemorrhage control. So where do we go first? That's the question. Should they come to the emergency room, as I think most of our trauma centers will end up in the emergency room, but really for how long? Is there a mechanism we can get them out of the emergency room really quickly? Should they bypass the emerge and get right to the IR suite? I think that'd be pretty unlikely in most places, for sure. Should they go directly to the operating theater? Just check in at emerge. We know from pre-hospital they're pretty sick. Let's just take them right to the operating room. And then it'll be, the IR part would be more actually in the operating theater. So I guess we have to figure out, well, again, it's almost like real estate. Location, location, location. For trauma surgery, location and geography is very important, but then resources are really important. Not just the physical resources, but the personnel resources as well. So here we have a bunch of different modalities that you can use to control or arrest hemorrhage, and the timing is variable for sure. It'd be different in many places. If we look in the emergency department, we can get most of those things. We really don't have an operating theater in our emerges, maybe close. Interventional radiology, okay, we can get many of those things as well. I think importantly, taking a step back with the emerge is the importance of having a really close access and readily available cross-sectional imaging with the CT scan. In the operating room, we can do almost all these things. Some might be able to do some advanced imaging in the operating theater. We certainly can't. But you can bring interventional radiology to your operating room if you don't have a hybrid suite. But then there's this hybrid suite, which is like the panacea. That's the, it's what we're trying to shoot for, where you think it makes intuitive sense. We can do everything that you need to do. If you identify this patient who is in hemorrhagic shock, you need to intervene to save the patient's life. You can get everything you need in a hybrid OR, and we'll come back to that in a little bit. So in the emergency room, you need to have all the right resources there. You need to be in a good location. As Dr. Ordonez was talking before, his CT scanner is 20 meters from his emergency department. You need to have a dedicated trauma team. In order to get that dedicated trauma team down to the emergency department, again, the right resources, you have to have adequate way for trauma team activation. And it's something very intuitive. You think, well, of course, we all have trauma team activation, or we might do. There's a trauma, we'll call the trauma team. And it's incredible when we really look through the literature to try to see what are there standardized activation criteria that would work across the board. So one of our fellows, Jake Pace, looked at this, and this will be coming out shortly, published shortly, but did a systematic review on trauma team activation criteria. Looked at over almost 40 observational studies from across the world, and noticed there aren't any stars over South America or Central America, unfortunately. But in looking at came across 42 different sets of activation criteria, 169 different criteria, and none were universal to all the studies. None. Most common, of course, would be the similar ones that we think of, some major physiologic and then penetrating mechanism. So what we did in London, this is our initial trauma activation criteria here, where we had 18 different points to look at. And we thought, how can we sort of key this down to actually those criteria that are going to be more resource dependent, that are actually going to require the trauma team activation. So then we've come across, and we've actually, this is our new criteria here, and I'll kind of walk you how we went about this. So we started collecting some data to look at all of our activation criteria initially with our initial trauma team activation, looked at those that were more resource dependent. So of those that were more resource dependent, those that would involve something that the trauma team would need to be involved with, we pulled those out, reformed our new trauma team activation criteria, which is what we see on the right, and then we implemented those over the same time period where we drew our first initial data from. And in doing so, we wanted to have a look at really what happened with our under and over triage rates. And before we did this, we were about 30% under triage, about a 30% over triage. When we implemented our new trauma team activation criteria, so we went from about 18 down to about 10. We improved them both, but our under triage rate's still probably a little bit high, and we've been looking into various mechanisms into reason why that's been. But suffice to say that the uptake was with a smaller number of criteria. We're adhered to it a little bit better, and certainly the emergency physicians who are going to be triaging this, for the most part, really bought into it. So we know we need the right people in the emerge. We need to have the right geography there. We don't want to mess around, though. Time is of the essence. Time for sure. What about going directly to interventional radiology? Well, that's probably unlikely, but I think we have to think about this as if we're going directly to, say, a hybrid OR. And interventional radiology and transcatheter control of various hemorrhage is in our armamentarium. We've been using this for years now for solid organ injury and abdominal vasculature. But really, the bottom line is that most of the time we want to do this is after hours. And calling in our interventional radiologist, like most of us, the interventional radiologist is not in-house. We've got to call them, we've got to wake them up, they've got to mobilize the whole team, they've got to come in, they've got to set up. This is a long time it takes to get this mobilized and get this done. But time is of the essence. We don't have that much time. So we need to change things around a bit. This is a nice paper from the group in Pittsburgh and Dr. Peitzman that really looked at the NTDB data, the study, on hypotensive patients who underwent therapeutic vascular occlusive IR procedure. So basically getting angioembolization to stop some bleeding. Here again, the delay to IR was associated with a greater than twofold increased risk of mortality. Every hour delay to the IR, the risk of mortality increased by 47%. So again, staggering numbers. It's something intuitive that we know, but now we've got some data to support that. So really, what's our role in this? And this is on the board from Chad. And really, we're certainly more on the left-hand side of the screen here. So we can kind of break this down into those that are emergent, life-saving, immediate. And here we've talked a bit about the RABOA. And clearly this would be something that is in our bag. This is in our game, for sure, as trauma surgeons. Those that have had perhaps a bit more advanced vascular training may feel comfortable with transarterial embolization. So that might be there as well. But on the right-hand side, where it's a bit more of an urgent scenario and not emergent and immediately life-threatening, would be for stents and sense grafts, and those would be probably left to the endovascular experts, and whether that is the vascular surgeon or the interventional radiologist, or a combination of the two in your facility is very dependent on that. So who would go direct to the OR? This is not a new concept for sure. Intuitively, it makes some sense. And here's one of the first papers I could find on those patients that went directly to the operating room, certainly in North American literature. And again, in Louis, this was pioneered in Louisville. And it was Dr. Griswold who did this for his penetrating cardiac injuries. And this was back in 1954, but had been doing this from the 40s, really coming back from the Second World War, identifying patients with a cardiac injury, and that's all they did, is identified those patients in the operating room, had bad physiology, into the emergency department, bad physiology, right to the OR. So they just basically stopped for a second in the emergency department, right to the OR, found that this really improved the care and the outcome of these patients. One of his trainees, Dr. Knorr, again took this to the next step. And what about the multiply injured patient? And again, like many things that we've learned in trauma resuscitation that stems from military conflicts, this is nothing new to the military surgeons, for sure. Someone's severely injured, they go right to the operating theater. And so here, Dr. Knorr just branched this out into the multiply injured trauma patient, mostly penetrating injuries, but again, found a subset of patients that you could identify who were very sick, hemodynamically unstable. They did best if they went directly to the operating room rather than spending time in the emergency department. So intuitively, this certainly makes sense, but really when you try to roll this out, logistically, it's very difficult. So we need to identify which patients are the perfect patients to do this. How can we optimize these resources? And it's very resource intensive to have an OR available 24/7, fully staffed, in order to deal with these types of patients. And again, because of that, it's very, very dependent on your local environment. One of the American hospitals that has probably had the most experience with this would be in Portland. And Matt Martin wrote a really nice paper on this, looking at a decade of their experience from 2000 to 2009. In their hospital, they had almost 1,400 direct OR admissions, and that was really only 5% of all the traumas over this period. So again, it's not a huge amount of patients that they see from their trauma. 5% of all the trauma, about half were penetrating. And I think what's interesting, only 16% would be as we would classify as being hypotensive. 16% of those patients had a pressure of less than 90. These are their indications and their personnel. And if we look at the personnel, it's about 12 people you have to have ready to get this OR going. And their indications are somewhat broad. They're not a definitive, it has to be this, that. What they do have is they have a nice geographic layout, of course. Come into the emergency department, you have the ED trauma bay, CAT scans right across the hall, or you can keep going down the hall and go to one of two trauma operating theaters. So these ORs tend to become resuscitative, an extension of the resuscitative rooms, but you just happen to be in the operating theater if you need to be there. And what they found, again, the difficulty here is that they're comparing this to TRIS methodology, but overall when they looked at this over that time, they had about a 50% reduction in mortality of those patients that went direct to the operating room when you compare it to what their TRIS methodology would be, so what their expected survival would be had they not gone there. So they can conclude from that they're saving lives by going direct to the operating theater. I still submit that most of our trauma centers really don't have a well-established, direct to OR policies. There is a significant debate really about the cost effectiveness and the sustainability of it. And then again, most of this data is using TRIS methodology, which again is, we can argue and debate that, I suppose, but really it's the only thing that they really can compare things to with regards to their mortality data. So what about the hybrid OR? It sounds cool, sexy. Here you can do it all. Your percutaneous procedures you can do in this exact same place where you're going to do your ongoing resuscitation, your open interventions, it's an ICU, it's everything. We can cover the whole spectrum. Diagnose, investigate, intervene, treat. One-stop shopping for sure. And I think we're going to be seeing this as a bit more now as our vascular surgeons have certainly got on board with having their dedicated vascular hybrid ORs where they have this great radiographic intervention. It may not be built for trauma, but we can use them that way if we have a good relationship with our vascular surgeons. So here we have the RAPTOR in Calgary. So we've got Dr. Ball and Macbeth and Kirkpatrick that are here from Calgary. And so for those of you that aren't quite familiar, Calgary's out in the west side of the country in Alberta, typically was a very rich province, I'll say, mainly based on oil, still quite a rich province. And this was really one of these first dedicated hybrid ORs for trauma in the world. It took a tremendous amount of fundraising to get that done, but they were one of the first to get this out in the world. And what does RAPTOR stand for? Resuscitation with angiography, percutaneous techniques, and operative repair. As you said, it's quite expensive, and as we tend to go back and forth, the haves and the have-nots perhaps, and Dr. Ball often calls it the room and place that oil money retreats to. So it's an expensive room to have for sure. Well, who goes to the hybrid? And again, sometimes it's difficult to define the exact patient that's going to be going there. In Calgary, what they've used would be confirmed and sustained shock, and they've got confirmed or high suspicion of intracavitary hemorrhage. So a bit more specific than the Portland group, where they had a bit more of a broader indication to go directly to the operating room. So these patients are trying to, get out the sickest, the trauma patients. That's a nice paper that the group wrote on really how can we get this right. So this was really just a retrospective look of all those patients that are the sickest trauma patients. So these patients are the ones that, they may benefit from the RAPTOR. They may benefit to be in an OR where we can do everything. They may benefit from this one-stop shopping. Of these patients, the vast majority of them that are hypotensive, they required some type of intervention. And looking through all of these patients, almost 1,000, they found about 35 that would benefit from probably the RAPTOR. So around 4 or 5% that would benefit from having percutaneous intervention as well as an open intervention and being done in one-stop shopping. And here again, this was a pelvis, liver, or both was what they were looking at. They did find is that you could probably decrease the time getting them straight to, decrease the door to IR needle, so we would be able to get that done much quicker if we could bypass and get up into the RAPTOR suite. And if you're able to bypass the emergency department, get to the RAPTOR, found that their over-triage rates with just a single low blood pressure would be about almost 50%. And if it's persistently hypotensive, still an over-triage rate of 40%. So again, we're still trying to find how do we identify that ideal patient that would benefit from going straight to the hybrid room or even to the operating theatre, I'd submit. Well, this is what we have in London, Ontario. We're part of the have-nots. But anyway, no, this is just to say that you can bring your IR to the OR. You can bring a C-arm and you can do these things. Your vascular surgeons and your interventional radiologists aren't going to be really pleased and they're not going to think the pictures are great, but you can do this. And in all truth, we do have a vascular hybrid OR and we have a great relationship with our vascular surgeons and we're able to use their OR for sure. So we don't have a RAPTOR room, but we've got something a little bit better than what I've just shown here for sure. So in summary, I think in our current state, in North America, Central America, South America, most patients are going to at least be in the emergency room for a few moments to identify who they are, what's going on, and then time is of the essence. There the decision is made, go straight to the operating room, or can we do like Dr. Ordonez has, where they're still unstable, maybe we can get to the CAT scanner and help us before we get to the operating room or not. But it really all depends on what you have around you, and not just the personnel, but certainly the financial side tremendously. The whole goal is the same. We need to get the right people, both the patient and the personnel, in the right place to identify and stop the hemorrhage. Well, I think what really is still very important is to have institutional guidelines. And once these have been implemented for trauma team activation or resuscitation or who goes direct to the OR, to the IR, to the hybrid, are really essential. And revisiting these. That's it. Thank you.